In the short time we have together, we'll focus on 4 key objectives. The first key component will be an introduction to proper soft tissue isolation techniques. Then we will look at proper utilization of today's impression materials. After that, I hope to share with you a relatively new technology that allows retraction-free final impressions. And then finally, we'll wrap up with a general overview of the current digital impressioning marketplace. We capture numerous impressions around the world on a daily basis. Unfortunately, we work in a wet, dark, and at times bloody environment, where we must capture margin with incredible accuracy, so that ultimately we have a crown that fits near a 50-micron gap. Unfortunately, this harsh environment we deal with can hinder our success, and technicians report that nearly 90% of all impressions that are sent into the laboratory have an observable error. We all know that if we start with a poor impression, there's no way we can have a well-fitting indirect restoration at the end of the day. When we look at the literature and start to see the types of errors that occur, 50% of errors are voids or tears at the finish line. There are numerous other errors that occur as well, as you can see from this chart, and many impressions have multiple errors. That is why the number on the right-hand side of your screen adds up to more than 100%. The good news is that we can make impressions predictable and greatly minimize the number of errors. Impressions do not have to be a fact of luck. In reality, it's all about technique. We don't have to feel like we got lucky when an impression is taken out of the mouth. It is all about technique, and I hope to share a lot of that technique with you today. Now, you can only image or take an impression of what you can visualize. It's really important to think about this. As of now, there's no technology in the marketplace that allows you to see through tissue without exposing the patient to radiation. So today, from a digital impressioning standpoint, there's no technology, digital or traditional, that we can see through tissue. Therefore, we must manage soft tissue retraction. Soft tissue retraction is really the key to proper impressioning. So in this case, we have a digital impression that was taken. Now, digital impressions can be very predictable today. However, with digital impressioning, soft tissue retraction is still a must, and in some ways even more important. By no means, if someone goes digital, are they free of soft tissue management. In many ways, it's actually more difficult in terms of soft tissue management. If you think about it this way, impression material, when a force is applied, can flow to places. Optics cannot flow. So if tissue is overlapping a margin, there is no way we can image it. On the other hand, impression material may actually flow there. So you can only image what you can see. It's very important to take that into consideration. I'm going to put up a series of impressions and or models that were fabricated here. In some cases, you'll see some digital options. And in other cases, you'll see traditional materials. So in the top side of the screen, we have iTero, a model that was fabricated, an Aquasol impression, one taken with Splash, one utilizing the 3M Lava COS scanner, or now True Definition scanner, another one using Ultradense Chromaclone, and finally Imprint 4. If we look at this slide, we can easily see that each and every one of these digital and traditional impressions has crystal clear margins. And while very good technologies and materials were used in these 6 cases, the success of the impressions was primarily due to soft tissue management. In every one of these cases, a dual core technique was used. Now, I agree, core placement can be very cumbersome. It's a cumbersome process. But the reality is that it can lead to beautiful results. The same can be true when utilizing soft tissue lasers. So if you don't like to utilize cord, soft tissue lasers can work very well. Now, success is not solely about the material or technology. It's about developing a predictable technique. As I said, each and every one of these impressions had the exact same technique, taken by multiple practitioners. They all had the same technique. Now, we must sit back and think the goal of a final impression is to record 0.5 to 1 millimeter beyond the restorative margin. If the sulcus becomes a target, everything coronal to it should be captured. We need to give the technician the ability to easily see our margins. so they can make well-fitting restorations. In my opinion, there's 4 keys to capturing high-quality final impressions. We'll cover each of these in the duration of this webinar. The first is we need really well-refined preparations. The second is to control the soft tissue and hemostasis. The third is to use high-quality forgiving impression materials with the right viscosity depending on the job you're trying to accomplish, depending on the task at hand. So one viscosity may not fit across the board. We also want to utilize the right tray. A full arch impression tray is always a great thing, but the reality is a lot of triple trays are used in private practice today. So can we develop a series of best practices when looking at triple trays? So we'll talk about those concepts. Now in this case, there's 4 anterior teeth were prepared. And I truly believe that these highly refined preparations help lead to improper impressioning. The more refined a prep is, the easier it is, quite frankly, for impression material to flow around it. The very last of all my preparations is take a fine diamond around all of my margins and all the axial surfaces. Today's cements are very good, and the reality is I'm bonding most things in, so I'm not too concerned about micromechanical retention of an over-refined surface. We don't necessarily need the roughened surfaces that we needed in the past with cements like zinc phosphate. Today's resin cements, resin-modified glass ionomer cements, have tremendous retention properties, and now we can have very well-refined preparations for traditional impressioning and or digital. They work well for both. Generally speaking, for my all-ceramic preparations, I use single-use burrs for my gross reduction. And single-use burrs today by companies such as Microcopy, Premier, or Dentsply perform very well and are a very economical price point, where they're usable for most practices. In some ways, I can't afford not to use a single-use burr because they tend to be more efficient. I'm done my preparations at a faster rate. Now from there, in terms of refinement of preparations, I think it's totally reasonable to use a multi-use burr. If these burrs are not responsible for gross reduction, rather the burrs used more for machining of the preparation, a fine contour of the preparation that comes about. So these burrs can withstand numerous sterilization cycles without getting damaged. We're not looking at those fine diamonds for refinement, for gross preparation, we're looking at them for refinement. After creating well-refined preparations, we must focus on proper soft tissue management and take things like hemostatic agents, cord, paste, and lasers into account. As I mentioned earlier, I believe cord and lasers do the best job, but we will cover all these categories. In the image to the right that you can see, we have margins that are at the tissue level or slightly below. And in part of it, you'll see there's a fair amount of tissue that's actually covered with blood. And that's an environment that we face day in and day out. That margin is a little bit on the deeper side. Now, to get a predictable impression of this area, we must control that sulcular fluid. We must retract that soft tissue. It must get that bleeding site or the heme under control in order to have a nice marginal fit of our end restoration. In terms of hemostatic agents, my go-to agent is really ferric sulfate. Now, Viscostat happens to be a brand name of one of the manufacturers out there that I use, but ferric sulfate is really my go-to, and my secondary agent is aluminum chloride. And we'll talk about each of these and really the best practices of either material. In terms of ferric sulfate, I use ferric sulfate in nearly all of my posterior cases, and then some selective anterior cases where I see some heavy bleeding. Now, one concern with ferric sulfate is that it does have a tendency to stain, and it can work very well, but it does have a tendency to stain. And at times, in provisionals that might not be properly sealed, it can help with causing a bacteroides growth, or black bacterial growth can occur onto the dentition. And many of us have seen this over the years underneath our provisionals, and hopefully not final restorations. Now, thankfully, if you get this kind of black scuzz disease or this black bacteria that grows there, for the most part, you can get that off with hydrogen peroxide and some pumice. So most of the time, it will come right back off. But that ferric sulfate, if there's a heavy bleeding area, does a very good job at clotting and then drying the crevicular fluid out. Now, in a case where there's not as much heavy bleeding, aluminum chloride may actually work pretty well. While ferric sulfate works better in heavy bleeding areas, in minor bleeding areas, aluminum chloride works quite well. And it's really something to consider. So a couple things in the market today. And there's one called Viscostat Clear by Ultradent. And if you like a more viscous product, a race gel by Septidon is another option that's out there. They both are 25% aluminum chloride, and they both work very well in minor bleeding cases, kind of minor to moderate. With more extensive bleeding, I would recommend ferric sulfate. Now the next thing I look at is retraction cord. And retraction cord has been around for a long time. It's by no means new. And it's really my preferred way in capturing impressions. Now my preference, there's two types of cord that are out there. One is a knitted and the other is a braided cord. My preference in retraction cords have a knitted cord and not a braided cord. I have found that knitted cords tend to have better lateral retraction. And in North America, two distributors of braided cord are Ultradent and Clinician's Choice. The vast majority of my posterior cases, I use a 00 or 0 as my apical cord. It's the first cord I place, get it all the way into the sulcus, and make sure there's no overlapping areas. So that initial cord, I really want it to be end-to-end flush into the sulcus. And I'll show you a photograph of that shortly. We put that into place, then we go ahead and use our hemostatic agents. And then my coronal cord, generally speaking, I want a 1 or number 2 cord. For the most part, it's a number 1 cord that I place coronally. In that coronal cord, I'm not looking for apical retraction. I simply want lateral retraction. I want to distend the sulcus so that I can predictably introduce impression material. And that's really the key. We'll take a look at the sequence in impressioning, and this is exactly what we do at the university with our students, and many others around the country do this. I'm going to take you to the detailed steps and then show you pictorially thereafter. The very first thing we do is we rinse our preparation and tissue with water. It's an aggressive water and air rinse. And we want to make sure there's no bleeding at that time. If there is bleeding, we'll go ahead and take care of it. We then aggressively scrub hemostatic solution into the sulcus through a dental infuser tip. This solution is then aggressively rinsed off, again with water and air. And if we see any bleeding there, once again we apply hemostatic solution. The reason we aggressively rinse with air and water is if we get bleeding with air and water, we're definitely going to get bleeding with impression material. So we want to make sure things are under control. After we get the tissue under control, we go ahead and place our first cord, tuck that into place so the ends are flush. And generally, again, that's a 0 or 00 cord. And then we lightly scrub the hemostatic solution on top of that into the sulcus. Do another air and water rinse, followed by placement of our second retraction cord. That second retraction cord always being larger. Generally a number 1 size cord, occasionally a number 2 cord. Once again, hemostatic solution is placed and then rinsed off. At this point, we let that sit for about 5 minutes. The reason we pick 5 minutes is 5 minutes tends to be the sweet spot between proper retraction and minimizing any kind of tissue necrosis. With patients that have thick tissue, we can really kind of get away with anything. Thick tissue is very, very resilient to any kind of cord packing, laser usage, etc. Thin tissue, on the other hand, is not quite as resilient. So at 5 minutes, the literature shows between 4 and 5 minutes is kind of the sweet spot where we get proper retraction without tissue necrosis. As we let the cord sit in place, you may choose to utilize an optional pre-impression scrub. Materials like Detail from Clinician's Choice, or there used to be a product called Prep Quick from Ultradent, can go in place and help clean the dentition off, almost leaving a surfactant across the dentition, allowing impression material to flow. It really kind of decreases surface tension. We go ahead and remove that top cord and introduce our impression material. So if we look at this pictorially, in stage number 1, we have our prepared tooth. You can see towards the mesial standpoint, we have a deeper area that's bleeding. We then go ahead and aggressively scrub that with our hemostatic solution, do an aggressive rinse, place our first retraction cord that will go all the way to place with a flush end. We'll go ahead and scrub that dentition again. We'll then go ahead and apply our second retraction cord. In this case, this blue cord happens to be a number 1 cord. We'll put that in place, and we let that sit for about 5 minutes after scrubbing with the hemostatic solution. You can then choose to use a pre-impression scrubbing medium. We do that, we let that sit in place again for about 5 minutes total. Go ahead and remove the cord, and when we remove the cord, what we expect to see is a wide open sulcus. Wide open sulcus all the way around the preparation. And when we get a sulcus like this, we can introduce impression material into it. We can take a digital image of it. In either way, we're going to have a nice, refined preparation that's accurately captured in either traditional impression material or digital impression material. A very predictable workflow. Now, this exact same technique was utilized in this impression. So there's 7 teeth that were impressed here. And the exact same technique was used. In this case, we used Aquacel impression material. Dual curve technique was utilized. And a student of mine, a senior student, about a year ago, took this impression. She did it all by herself. She knew the technique, went through a process, and captured this impression. The way we teach our students to capture multiple unit impressions is we ask them to cover all, once the cord is pulled, so we pull the retraction cord out, rinse as needed, dry the dentition off, introduce impression material at the lingual surface. So we pick a distal lingual line angle. In this case, it might be the first bicuspid or the second bicuspid. And we go through and go from a lingual standpoint and taking all the impression material in the scallop formation all the way through all the linguals, squirting slightly into the proximal surface, and then we come back and do all the facial surfaces. The reason we do that is we want to have a clear view of the field we're impressing. By capturing all the lingual surfaces first, when we come back from a facial standpoint, we're easily able to see our facial sulcus. That impression material is not in the way. If we start on the facial first, just gravity would pull that impression material towards the lingual, covering up our lingual surfaces. So generally speaking, we'll always do the lingual surface first. More often than not, we start the distal lingual line angle and continue on from there from an injection technique standpoint. And when we do that, as you can see in her impression, real crisp margins completely captured, plenty of flash or extension beyond the margin, and a laboratory technician should have really no issues in trimming the models that are fabricated from an impression like this. You can also see with her preparations how smooth the margins are, how refined those margins are, allowing impression material to flow very, very easily. So impression refinement plus soft tissue management and introduction of the material allows that to occur. Now, I fully understand that cord placement is tedious. Yes, we get great results from it, but it's a tedious process. Now, if you choose not to use retraction cord, as I mentioned, a soft tissue laser would be my next favorite choice. However, you may decide you like paste systems. So there's many pastes on the market. There's Expasil by Kerr, Traxident by Premier, retraction capsules by 3M, etc. There's many that are out there, and if these are working for you, I think that's great. In my hands, they tend not to work as well, but I do see that for some people they work very well. Now, I do believe that impression paste, I think, is a reasonable choice to replace the second cord in the dual cord technique. So if you want to use like a product like Expasil or Traxident, I think that's reasonable to do. Go ahead and place your initial retraction cord with the Hemostatic solution, rinse that off, and then introduce some kind of a paste system for the coronal portion that can then be rinsed out. I think that's a reasonable process to be able to do. Now, in my opinion, as I mentioned, the next best thing is really a laser troughing. Is really the next best thing to do. And in some cases, this might be your favorite one. I have no issues or problems with this at all. Lasers can work very well, and they're relatively fast. As you can see in this video here, Dr. Van Ass out of Canada is taking care of some soft tissue that's around a preparation. He's going to very conservatively remove an internal layer utilizing AMD's laser. He'll go through that process, and it's very atraumatic. Patients don't really feel this as much. There's little to no postoperative sensitivity. Many would argue postoperative discomfort is actually less than that of cord and pressing onto the tissue. So I have no qualms with using a soft tissue laser at all. And in this day and age, quite frankly, I believe everyone should have a soft tissue laser in their office. They're not the price points of $10,000 to $15,000 they once were. Rather, they're a price point of roughly $3,000 with products like AMD's or Denmats. So something to consider there. As you see Dr. Van Ass go around, he's removing this tissue very conservatively, is not charring it. We're not seeing any significant black or brown marks. The laser energy is appropriate. And we'll get a nice open sulcus all the way around the preparation. Once that's completed, there'll be some tissue tags that are present, and you can just take a little bit of hydrogen peroxide and a dental infuser tip and go ahead and clean that area off before drying the sulcus and capturing your final impression. So you'll see through the mirror here, we have a nice open sulcus all the way around the preparation. If there's any remaining tissue tags, you can always go back in, cleave those out until you get a nice comfortable open sulcus that you're ready to introduce impression material into. Here you can see at a high magnification, works really well. Lasers tend to work really well for soft tissue management. After soft tissue management is done, we have to think about the materials that we're using. And we must control the application of this impression material. Thankfully, all top-tier impression materials today are pretty darn good. And the three depicted here, they're all excellent. In my opinion, technique is what's most important. However, we must keep in mind that if you have great technique in poor materials, they can come back to bite you. Great technique with excellent materials, you have the best of both worlds. You can have very, very nice impressions. But if we mix poor materials with great technique, you can do everything in the world and it may hurt you at the end of the day. So we want to utilize great materials. When I choose an impression material for the office, I like to have a multitude of viscosities. Now this isn't going to cost you any more. Yes, there'll be some more inventory, but whether you pick a rigid material or a light body material, the cost is essentially all the same. The reason I like to have multiple viscosities is because I want the right viscosity for the job to be done. I use each viscosity differently. In addition, I want both a slow and fast set, and I want a material that has a high tear strength. So in terms of viscosities, in my office I'll have a putty material, or rigid, a monophase, a light body, an extra light body, and I use all these differently depending on what I'm doing. At the same time, if I'm taking a single unit impression, all I need is a fast set material. If I'm impressing 5, 6, 7 teeth, then I need a very slow setting material. So we don't want to unnecessarily leave an impression tray in a patient's mouth longer than it needs to be. We want to use what's appropriate. We'll go through a few different techniques here. So forgive me as I go through these with you and how I use multiple viscosities. For a multiple unit impression, and I'll define multiple unit impression, if anything really more than 3 teeth. If I have more than 3 teeth, what I like to do is a 2-step putty wash technique. So I mix up some putty, I put it into a tray, I mold that tray onto a model or maybe in the patient's own mouth, and then create a little spacing around any preps that I want to impress. Let that set. Once that's set and I have the proper amount of room around my preparations, I then go ahead and introduce an extra light body wash material onto the dentition as well as into the putty wash tray, and I go ahead and seat it. The benefit of that is I get some compression force from impression material into the multiple preparations. Now for 2 to 3 teeth, a much more simpler process. I'm not as concerned about the tray. I still use a full arch tray for multiple teeth. In this case, I use a monophase material with the extra light body wash again. Do it all in one step. And the reason I use a monophase here is I get enough stiffness in the material to get some compression force. But at the same time, the material is not so stiff that I'm concerned about it locking into places and not being able to remove the tray. For implant impressions, I utilize a monophase material with a light body impression material. With implant impressions around implant posts, we want some rigidity. We're not generally going into really, really deep sulcus. We want impression material light body to go around the fixture connection point, but it's not going into the traditional sulcus like we would have with a crown prep. For single units, I like to use a rigid impression material with an extra light body wash and a triple tray. And I use triple trays all the time for 1 to 3 teeth. For 1 tooth with adjacent teeth that are stable. Beyond 1 tooth, I tend to use a full arch tray. But for a single posterior tooth, first bicuspid to the first molar, I think triple trays work really well. Invisalign cases are a little bit different with clear aligner therapy. With clear aligner therapy, when I take those impressions, I use a putty wash combination again. But rather than doing a 2-step approach, I do a 1-step approach. So in this case, I'll take a putty type material, mold it into the patient's mouth with some cellophane, and I'll remove that cellophane, then introduce a wash material before the material has been set, introduce that back into the mouth so we get nice compression around all the dentition for a highly accurate impression. So a mix of different viscosities depending on what we want to do. As far as setting time, I like to use different setting times that really kind of ease my stress levels, yet minimize the amount of time the tray needs to stay in the patient's mouth. I use fast set for 2 or less units and regular set materials for greater than 3 or 4 units. When I get beyond 3 or 4 units, I like to use an extra long working time material. If I'm taking an impression of 10 teeth, I don't want to be stressed the material is setting up. So in those cases, I like to use an extra long working time. At the same time, if it's one or two adjacent teeth, relatively straightforward impression, let's minimize the amount of time we need to leave that tray in the patient's mouth and really improve their experience. Now, when selecting an impression material, I think it's really important to have a high tear strength material. There's nothing more frustrating than doing all the soft tissue management in the world, and then you go to remove your impression, and upon removing your impression tears. And the impression material, there's flashes remaining in the sulcus. So you want to have an impression material that has high tear strength. And if you look at the top tier impression material today, whether it's Aquasil, Imprint, or Virtual, they all have pretty darn good tear strengths. Historically, fast set materials had poor tear strengths compared to regular set materials. That's not necessarily the case today. What this table is really showing you is, a study was done to say, well, when we remove an impression tray from the mouth or a model from a poured impression, should we do that slowly or should we do that very fast? And the research by Dr. Lawson and Burgess has showed that we really want to remove the impression tray once the material is set as fast as possible. We can really maximize the tear strength properties when we remove a model quickly from an impression tray, or you remove an impression tray quickly from the mouth. If we tease that impression tray out of the mouth, there's actually a higher tendency for that impression material to tear. So quick removal is really what's advocated. Now in tray selection, I would always say that a full arch tray is really the best thing you can do. And there's really no downside to using a full arch tray other than potentially comfort or amount of impression material that's being utilized. But the reality is a lot of triple trays are being used. That's the reality of practice today. So if we're to use a triple tray, I think we need to consider best practices. And triple trays work very well, and quite frankly, they're the only dynamic impression that we have. By dynamic impression, I mean when you bite into a triple tray, when you have the patient close into centric occlusion or maximum intercuspation, when they bite down, the PDL is activated. The teeth depress slightly into the PDL, and that is a truly active impression. When we take a traditional full arch tray, it's really a passive moment. There's no compression of the PDL that's occurring, and then we take two stone casts and mount them against each other. So for a single unit, articulation actually works really well with a triple tray, really high accurate results. Now I tend to use triple trays from first bicuspids to first molars for single units. I don't really like them for anterior teeth, any teeth that are in guidance or implant components. Nor do I really use them for multiple unit cases. So for any multiple unit case, second molars, anteriors, or implants, I always use a full arch tray. But when looking at triple trays, I do like to have a rigid outer surface. So we see these trays by Denmac, Clinician's Choice, and Premier. They all have a more rigid outer surface that's there. I also have to have a low profile distal extension and a flexible mesh. If we have a flexible mesh combined with the others properties, the patient can comfortably close into this tray and bite down without the mesh holding the dentition up. I do think that's very important. Now one tray I like in particular in terms of triple trays is this one called the Trio tray. It's distributed by Ultradent, and I'm going to play this video to show you how it works. It incorporates many of the properties we discussed. It has a nice rigid metal outer components, nice and rigid, so there's no flex. But yet the mesh that's inside is a disposable mesh. The mesh has some flex to it. When you take this Trio tray and you load it with impression material on both sides, obviously, for the maxilla and the mandible, we have the tray loaded, and when we introduce into the patient's mouth, there's wash that's been placed around the prepared dentition. The tray then goes into place, and as the tray goes into place, you'll see the distal component clear the retromolar pad area. The patient will bite down. Because there's a rigid medial surface and a rigid lateral surface, there's nowhere for the impression material to go. The impression material is forced to go into an apical direction. So we get some kind of hydraulic flow, some hydraulic benefits to this technique as well. So I want to show you a clinical example of that in the case that we did utilizing Aquasil. So in this series of photos, a single unit molar has been isolated, and a monophase material is being used in the Trio tray with an extra light body wash around it. So first we have a dual cord technique isolation. You'll see the top cord is there. That cord will be removed. Impression tray will be loaded. Wash material will be introduced around the dentition. And here's what the tray looks like with the impression material. we see nice detail in all aspects, a nice compression force that's occurred. And if we zoom in on that impression, highly detailed impression, plenty of flash, lots of crispness to the margin. Again, there's really no question as to where that margin is. Now, is that combination of hydraulic flow being utilized in the tray in addition to soft tissue technique and proper material. So to capture an accurate impression, proper syringing the material is very important. We'll discuss a few things in relation to that I think can really help you out. The industry is also moving towards a unit dose basis for impression material delivery, moving away from the traditional guns that we've had to more of a unit dose method for cleansability, ease of use, and really predictability and control. So I want to take you through a few things with syringing technique. To deliver impression material, really one of two techniques is utilized historically. In dental school, many of us use this free flow impression syringe. This one happens to be by Kerr, but there's many others that have been made. GC, 3M, etc. all have these types of syringes. And in this syringe, traditionally, we introduce material either from the back end or the front end by taking this cap on, taking the cap off, depending on which philosophy you believed in. The real benefit of a syringe like this is we had control. It was in the palm of our hands. We can precisely deliver impression material at the point of sulcus. Now from this point, the downside of this technique, however, was as soon as the syringe is loaded with impression material, it could potentially start setting. So from that point, manufacturers created these yellow intraoral mixing tips, or yellow intraoral tips with a yellow mixing tip. The benefit of a tip like this is you have fresh material at time of delivery. Now, in all honesty, I have to say I personally hate these yellow intraoral tips. I believe they're the cause of why a lot of impressions are missed. We need to capture a margin with tremendous accuracy. And this is very, very hard to do when we're squeezing a trigger on an impression gun that's nearly 12 inches away from the impression material being delivered. It's too far away from the point of concern that we need to really be up close and personal. And that was the benefit of the free flow syringe. So in an ideal world, we would have fresh material at time of dispensing, a very comfortable operating position, we have a clean environment, less material waste, and really better visualization and control. If we have all those factors that are there, the chance of getting an ideal impression definitely increase. And to that extent, manufacturers such as Kerr and Dentsply have created unidose products that really take this mentality into account, where impression material is delivered at the sulcus directly in a comfortable position where we can squeeze the palm of our hands, or our thumb and our forefingers. So this is a move in the right direction. In Kerr's case, I really like the size, the syringe that's in your hand. In Dentsply's case, the Oxyl Ditch, I love the unidose factor that's there. At times, I believe that syringe is a little bit large, but both work very well. There's definitely much more control than traditional delivery systems. Now, other manufacturers have said, let's take the concept of unidose delivery in control and put it into a simple syringe. So this is a syringe called the Mojo syringe. It's manufactured by Danville Dental Materials and Ho Dental Company in Las Vegas. And what this does is you can essentially pull this plunger out, introduce your impression material cartridge, so you have an A and B side, so your base and catalyst. It'll fill this syringe. The syringe is filled, can take impressions of 3 to 4 teeth. When you push on the plunger, it then goes ahead and starts mixing through this cannula. This can fit in the palm of your hands. And that material that's there, and the total, if we look at the material, if we look at the total syringe itself, it's about 90 cents in cost. It's meant to be used with a polyvinyl material, and there's incredible control. We get the benefit of a handheld device that has fresh mixing of material for precise control and delivery at the point of really where it matters. 3M's come out with a similar device. It's a very similar concept that's roughly the same price point, maybe a little bit more. They also have a polyether option as well. I really believe these handheld units for 1 to 3 teeth, maybe 4 teeth, work very, very well, and something to definitely consider if you're struggling with the traditional yellow intraoral tips. Now, in an ideal world, if we think about all the things we discussed for the last half an hour, what if we had an impression system that can get rid of those things? What if we had an ability to be cord-free, to have a high tear strength, to have precise placement with a small tip? Really, that would be ideal in many cases, if we can have all these benefits combined into one product. And this is really what industry's been looking at. And I really give credit to Dentsply to take a look at saying, can we change traditional impressioning? Now, traditional impressioning has been changed with digital, but maybe you're not ready to make an investment in digital. So can we change traditional impressioning by looking at other technologies, still using a polyvinyl material, but utilizing it in a way where we have tremendous pressure that's being delivered to the material, using technology to deliver the impression material, and getting a precise impression without having to go through traditional core packing. And that's what really Dentsply did. And last year I had the benefit of being part of the Pride Institute. And last year we recognized this technology is really a best in class. It's essentially an impression handpiece that hooks up to your handpiece tubing so that a significant amount of pressure is applied to the impression material, and that impression material is controlled but forcefully delivered into the sulcus. What's occurring here. What I like to do is play a video for about 90 seconds, and it'll show you a comparison here with traditional core placement versus impressioning with Aquasil coreless, and seeing the difference in time.
Today, we will compare
what you'll see here is on the left-hand side of your screen, you'll see traditional cord. On the right-hand side of your screen, you'll see delivery, a really innovative impression material through handpiece technology.
By utilizing air
so as we all know, placing retraction cord is a tedious process. It takes a while to get it in place.
Ultra cordless is to use. It places super high tear
and so the left-hand side of the screen is going to be sped up and shortly here. In about 14 seconds, the impression material has been delivered into the sulcus with Aquasil cordless. On the left-hand side of the screen, you're still seeing the cord being placed. So about 3 minutes into the impression, cord being placed. By 25 seconds into the impression, the triple tray has been placed. We're ready to have the patient bite down.
The dentist waits
so once that occurs,
for the
normal set time happens. At roughly 8 minutes from starting point, impression material is introduced on the left-hand side of the screen.
After the required set times have elapsed,
roughly 11 minutes from start time, impression material is removed.
As you can see,
so you compare 12 minutes to 4 minutes roughly here. There's roughly an 8-minute time savings that's there, but there's a lot less potential trauma that's occurred to the patient. The question we have to ask ourselves is, well, do we get an impression with nice marginal detail? That's really the bottom line. Yes, there's a time savings, but we need to have an impression that's crisp, that's accurate, that our technicians can go ahead and create proper restorations on. So now the actual finish lines will look a little bit different. In traditional impressioning, we were having to have soft tissue or retraction with a cord and or a laser. Impression material can be a little thicker around that aspect. With Aquasil coreless, on the other hand, as it's introduced, the impression material can thin out in places, but the question has to occur is, do we have enough of the margin captured? Is a margin captured in totality, plus do we have a little excess beyond it? The way we achieve that margin being captured is a really innovative technique. So something called the PowerFlow tip here was developed. A traditional impression syringe, this yellow tip here, has a 0.057 outer diameter compared to 0.034 outer diameter. So this tip fits into the sulcus much easier. It can kind of glide into the sulcus, hold in place, express impression material. So partly it's innovative tip technology that minimizes the need for any soft tissue retraction. Then going through a technique standpoint, that tip is oriented into the sulcus, a rheostat is pressed, impression material is delivered with some force or some pressure, goes around the entire dentition, and impression is captured. In stage 1, you still need to do hemostatic control, so you still need to use your hemostatic agents. But once you do that, there's no additional soft tissue retraction that's completed here. An impression is then captured. And quite frankly, there's a learning curve to this. And it's not a technology that necessarily impression number 1 out of the box is going to work, but you're going to need to get comfortable with it. And when we look at these impressions, we have to be critical. And we have to say, are we capturing the right amount of detail? Is there enough that's there? So I used Aquasil impression material for years. When I used it, I had very, very nice, highly defined impressions. When I saw some initial advertisements come out and I saw these pictures, I wasn't quite sure. And upon looking at those photos, I said, you know what, in my opinion, it's not quite good enough. But I need to try it in my own hands, because is it a technique issue? Is it a learning curve issue, or is it a product issue? And when I tried it into my hands, quite frankly, after about 10 impressions, we started to get really good results. So the first 10 cases, I think with any technology, we have to be okay saying that's our trial. Let's get used to the material. Let's get used to technology. It's something different. After about 10 impressions, we started to get some really good impressions. We started to see those same crisp margins with highly defined detail that we would see with traditional impressioning. So take-home message really is, it is a new technology, relatively new technology. It can be predictable, but there's a learning curve. Like anything, we need to be able to invest into a learning curve. And before we give up on a product, we have to go forward with that. So whether it's traditional impressions or new technology like AquaCell Cordless, I think they both work really well. Now, since that point, including that point in the last few years, we've seen an explosion in the CAD/CAM market. Sirona this year will celebrate 30 years in CAD/CAM dentistry. CAD/CAM dentistry is by no means new. However, the prevalence of digital systems is increasing every year. In the U.S. market today, there's many, many digital systems. As we can see all of these on the screen that are available. In the European and Asian markets, there's a few more that are out there, or different ones compared to what's been released in the U.S. Today, I can say essentially each and every one of these digital impressioning systems that you see on the screen, they all work, and they can all work very well. You have to decide for yourself what's right for you. In the remaining time we have, I'm going to give you an overview of the digital impressioning market today. First, what we want to do is loosely categorize what we call acquisition centers versus complete solutions. Many of the systems can do both aspects today. They can be complete or they can be simply be acquisition. But the intent of the system is what we want to look at. The intent of an acquisition center is to capture a digital impression. That is a primary goal. The intent of a complete solution is really prosthetic fabrication. The intent is to create a restoration at the end of the day. So primary goal in acquisition center is a digital impression. The primary goal of a complete solution is to take that digital impression and to create an end restoration. For today's presentation, we'll spend most of our time really looking at acquisition centers. Now, here's the really good news today. The good news today is that impression systems can grow. You may be at the point in your practice where you're considering new impression technology. That may be something like AquaCell Cordless. That might be a digital platform. If you decide to go in the digital platform, at one point it had to be a state where you had to buy all in. You had to go into acquiring impressions as well as creating restorations. Today you have a choice. Today you can start with an acquisition system, so to purchase something that creates a digital impression. That digital impression is then sent to a laboratory. Okay? Now 2, 3, 4, 5 years may pass. You may have an associate that comes on. You may have a partner that comes on. And you may decide you want to grow your system, that you want it to become something more. Well, as time goes on, you have the ability to add software to it and add a milling system to it. And at that point, you can decide some restorations you may send to your in-office mill, and other restorations you may send to your laboratory. And that'll be a choice that you have. The vast majority of systems today are what we call open platform, which I'll discuss shortly. When we think about an open platform, okay, really that's saying we can do anything with the data. So each of the business models I show you with the open, partial, and closed system, each of them have their own benefits, but they're different at the same time. An open platform is when you can take your digital impressioning system and that data set, which is traditionally something called an STL file, can be transferred to any other system out there. Meaning you can merge it with other cone beam CTs, you can merge it with milling systems, you can merge it with printing systems. It's a truly open platform. And that's a big benefit, is really freedom. The polar opposite standpoint has what we call a closed system. A closed system says a given scanner can only output to a given mill. It can only merge with a given cone beam CT, etc. It's a very closed environment. Traditionally, the CEREC or Sirona environment has operated in this closed environment. The benefit to that is really there's one person or one company that's responsible for the entire workflow. The downside to that is you don't have choice. So today, if I believe that, let's say, System A is the best impressioning system out there, and System X, made by another manufacturer, is the best cone beam CT system out there, today in a closed environment, I can't merge those two together. In an open environment, I can. Now, the downside of the open environment can be, well, you're asking multiple technologies and will validate his workflows. And if you choose to we got disconnected there for a minute. If you choose to use a different system, you can do so. And that's the open. Now, from an acquisition standpoint, here's 4 of the systems, or 5 of the systems, in the marketplace. Itero's out there. This is a new version of Itero. We have the Trio system by 3Shape. We have the True Definition Scanner by 3M. And we have the Dental Wings intraoral scanner, which will be coming to the States shortly. And all of these are what we call acquisition technologies that are present. In the restoration fabrication world, there's 4 key systems in the U.S. and many more that will come about. Sirona, fantastic system, has been around for a long time, and the Ceria platform does a really nice job. You have the E4D or Planmeca system. You have Carestream, or formerly known as Kodak, that has created an intraoral scanner as well as a milling system. And then finally, Glidewell, one of the big laboratories here in the United States, has come out and partnered and essentially took a controlling stake in a system called the iOS Glidewell, or TS150 milling system. All these can create restorations. In this iOS system's case, it can be merged with other scanning technologies. Now, another decision you need to make is to say, are you open to having a disclosing media or powder on the dentition? Years ago, we only had an option of powder-based systems. Today, we have the option of having no powder. Now, generally speaking, when we powder the dentition with a titanium oxide, a very light coating of titanium dioxide, we're able to scan the dentition quicker and easier in some ways. It requires a different set of optics. If we want to have optics that do not require any powder, well, that's a higher level optics in some ways, or a different type of optic system of scanning, and that generally adds about $10,000 in cost. So we go from a powder-based system to a no powder-based system. Generally speaking, we're going to increase in cost. And there's benefits on the other side of that equation. Another decision you have to make as a practitioner is to say, well, what system feels comfortable in your hands as well as maybe your staff's hands? Because in today's day and age, your staff may be involved in scanning the opposing dentition or any area that's not the preparation, and you may be involved in scanning only the prep. So this is not the most. There's some systems here that have changed over time. For example, the Lava COS system no longer exists. The iOS system has gone away as far as the scanning system. But it just gives you a rough sense of where wands are today, where the scanning wand or the camera, and what feels most comfortable in your hands. Now, I truly believe that digital impressioning is going to improve dentistry. In this case, one of our students at the University of Pacific took a digital scan of their preparation. They were redoing a crown. They took a digital scan, and the screen towards the left-hand side showed that they were under-reduced. We were asking for 1.5 millimeters of occlusal clearance in this preparation. They had 1.25. So the software highlighted to us an area where we had a discrepancy. So things like this allow our dentistry to get better because we're able to go in and change preparations before they're sent off to the laboratory. In another case here, here's a case of my own where I went ahead and scanned tooth number 19 for a full coverage restoration. You can see, in this case, it's the powdered system world that we're utilizing, or powdered system. The little speckles you see are the powder here, but you see a very crisp, defined margin. There's really no question for the technician where the margin is, and they can easily go ahead and fabricate a digital die and then print a die if they need to. Other systems in the marketplace, such as 3Shape's Trio system, have a color scanning ability. It's a very good scanner, has a color scanning ability. Here's another clinical case of mine where we went ahead, here's an intraoral view. We're going to do a 4-unit zirconia-based bridge with a veneering ceramic on the facial surface. Here's how it looked intraorally. Here's the digital scan of that same preparation, all in color. And another patient's case, or another usage of digital, is to utilize it from a treatment planning standpoint. So I still use impression material in my practice for different things. In many implant cases, I use traditional impression material. In Invisalign cases, I use traditional impression material. And there's other times where maybe the wand doesn't fit, so you might have to use traditional impression material. But in cases where I'm using digital, I can also use digital from a standpoint of treatment planning modalities and leveraging this technology from treatment plan presentation. So in this patient's case, they came into my office about 6 months to a year ago, and they said, "Doctor, I've never had a cavity in my life." And looking around their mouth, I said, that's a true statement. I don't see any restoration that are at hand. Now, if you look closely at the screen, you'll see a tremendous amount of erosion that's present. They were never told they have any problems. but both facial surfaces and palatal and lingual surfaces, we see a tremendous amount of erosion that's present. And what I was able to do is scan this patient's dentition of the maxilla and the mandible, digitally articulate these casts, and now show the patient from a palatal view or lingual view what their dentition looks like. One of the complaints they had is they're not chewing as well as they once did. Well, if we look at this patient's case from the palatal view, we see that the palatal cusps are completely eroded. Now, this is a completely different eye-opening moment for this patient, where with traditional model work, I may not have been able to do this with quite the same effect, because a yellow, blue, or white cast may not have the same results. But with the color rendition, this gave them a different perspective of their own mouth. So there's things that we can do today. I think every one of these modalities that are options to you today, with traditional impressions, things like aqueous cordless without having to traumatize soft tissue, or things like a digital impressioning system, all techniques are feasible. Every single one of them is feasible, and you can do a great job and create predictable restorations with all the systems that are out there today. That concludes the primary aspect of our presentation. I'm going to take a look at some questions here. I do think everyone that's been on the video is fantastic. I appreciate you joining me today.